Hello, this is Nida from Maharajas of Scale, and today we are at Aravind Eye Care, and we are here talking to Sanil, who has been doing a lot of stuff for our Jagriti Yatra folks today. So let's hear from him what he does and what is Aravind Eye Care and what is it doing. Arvind, welcome.
Hello, I'm Sanil Joseph, and I have been working in Aravind for the last 15 years. My background is hospital administration and public health. Currently, I focus more on health services research in eye care. That is the non-clinical aspects of research. Aravind the organization is called Aravind Eye Care System, which is a combination of a lot of aspects. It's not just treating patients for eye problems.
Yeah.
So Aravind was started way back in 1976 by a visionary leader, Dr. G. Venkataswamy.
Right?
Yeah. So he was an ophthalmologist in the government service.
Right.
In Madurai.
Yeah.
And he started Aravind after he retired from his government service at the mandatory retirement age of 58.
Right.
That's when people will look for an easy chair to relax.
Yeah.
So that is how Aravind started. That was the beginning of Aravind.
Yeah.
So then at the beginning he just started with his own siblings.
Correct.
Basically his sister, her husband, his sister and her husband.
Okay.
So a few of them, and all others were still working in government service. So they used to come in the after hours to support him, and he didn't have support staff.
Correct.
It was in a rented building.
Correct.
So he used to get nurses from the government hospital to come and assist him in the surgery in the evening hours. That's how they started.
Right.
And because he was in the government service, he has seen how what's the size of the problem of blindness and visual impairment in the community and how things are happening.
Right.
And he realized that government alone cannot provide all the healthcare that is required.
Right.
That is why he thought he'll do whatever he can, even after retirement from the. So that's how he started this initiative, and he had a great vision. That his vision was to eliminate needless blindness globally.
Right.
No, it might sound very strange. No, you are starting.
Yeah, and there is a huge scale, right? In the morning we were seeing this presentation, and you mentioned it from 11 beds to.
Now it is 98 locations.
98 locations.
Yeah.
Oh my God.
Yeah. So now maybe in a couple of months we'll be 100.
Yeah.
Locations. Our presence will be in 100 locations. And now we have. Of the 98 now, 77 are smaller rural vision centers.
Correct.
They're like primary eye care centers, which are manned by trained ophthalmic technicians, because we don't have doctors, enough doctors to be placed in villages.
Right.
But that is where most of the need is.
Right.
And these centers are all connected via internet to the base hospital, to one of the base hospitals.
Got it.
So everyone gets a virtual consultation.
Got it.
By an ophthalmologist.
Awesome.
So there is the quality is not compromised.
Right.
And we see that more than 90% of the problems can be dealt with at the vision centers themselves.
Oh.
So that's a huge economic saving for the community. No? Imagine all of them.
Right.
Most of them will not bother to if they travel to a distant town.
That's also expensive.
Traveling 30-40 kilometers. So typically eye problems are in the older age. Someone has to accompany the patient. It's a lot of economic loss for the community.
Correct.
And what they pay there will be a fraction of what they would have spent to come to a town. It's like 20 rupees, which is valid for 3 months. Or 3 visits. So we don't want to, so that people also will take it seriously. That is the idea.
It.
Yeah. And whoever requires higher treatments, or surgery, or higher examinations will be referred to the base hospital. So the idea is that no one should not travel more than 4 or 5 kilometers to access eye care. That's our goal.
Right.
So we'll need many more vision centers to be started to achieve this goal.
Yeah.
So that is a broad idea. And then we have other, like we have 7 outpatient clinics which are managed by one ophthalmologist and support staff. That is in semi-urban places. And then we have 7 secondary hospitals which can do all basic eye care procedures like cataract surgery and other minor surgeries. These facilities will have like 4 or 5 doctors, sometimes to 10 doctors. Then we have 7 tertiary level hospitals which can handle any complications in eye care. And there are also training programs and research happening. So that makes the 98.
So a couple of things that we heard today was about the operational efficiency and how Aravind brought about operation efficiency, especially having a certain number of staff. Okay. The second thing is about, it's a huge problem. For people who are blind, they would definitely know what the problem of blindness is. As a person who's not blind, I can only imagine what it can be, right? And touching a very socio-economic issue, right? That's huge. So, how important was the vision of Dr. V when it comes to solving both the socio-economic part as well as making it operationally efficient?
Yeah, so you're right in that it is not just physical disability.
Yes.
So when somebody is blind, it deprives them of many things like their social acceptance, their emotional well-being. All those things are affected. They are being deprived, and someone has to be there to assist them. So all those things makes them feel like a burden in the family and quality of life, all those things. It's much beyond physical disability.
Right.
So that way it's a very serious problem.
Right.
So that was one reason. That realization is why Dr. B had this drive, that he wanted to do something, and he knew the size, the length and breadth of the problem by being in the government.
Right.
And while in the government itself, he always used to go beyond the boundaries, and then he was part of the team that met the then Prime Minister, Madam Indira Gandhi, and got what we now have as the National Program for Control of Blindness, which supports the free surgeries done through the eye camps. So it's not only for Aravind, anybody can avail if they qualify certain criteria. So he was having that kind of a drive even then. So some people call him as the father of community ophthalmology because he's the one who took it to the community.
Correct.
I think so. The understanding of the seriousness of the problem, that was the drive. I think that's why he wanted to do something about it.
Yeah.
And he was a real visionary. And like many, I've only had a very brief overlap with him.
Okay.
I joined Aravind in 2015, and he 2005, and he passed away 2005 March, and he passed away in 2007 July.
Oh.
But I had a few instances where I had to work with him, fortunately. So that was the thing. That was his. So what I was about to say that. So I've heard from people that he always see beyond the near future.
Got it.
No, so people, it might not make sense to you when he talks about now we should do something like this.
Yeah.
No? While after visiting the University of Michigan campus, he said we should start something like that.
Right.
It doesn't make sense to anybody at that point.
Yes. Even saying things like we need to be like McDonald's, for example, it really. You want to correlate it, but it comes at a later stage. The correlation itself.
Yeah, he used to see, I think, like 10-15 years ahead of anybody else.
Yeah. I quickly want you to touch upon what are you do. Aravind is doing something with Google.
Yeah.
So what exactly is that project about?
That is so we collaborated with Google in developing an artificial intelligence platform for one particular disease to start with.
Right.
So there is a complication called as complication of diabetes,
Correct.
called as diabetic retinopathy.
Retinopathy, right.
Which affects the retina which is the back
Correct.
of the eye. And whatever happens to the retina is irreversible.
Right.
Like unlike cataract.
Correct.
Cataract, if you operate, you will get normal vision.
Right.
You can take out the affected lens and replace it with an artificial intraocular lens. You will get normal vision. So if you have refractive error, you can correct it with glasses.
Right.
But whatever happens to retina or that part, nerve, optic nerve, or that part of the eye, cannot be reverted.
Right.
And unfortunately, to add to the complication, this is an asymptomatic problem.
Okay.
There is no symptom.
Okay.
In the early stages.
Right.
Yeah. So by the time they get visual symptoms,
right.
the disease would have advanced to a very severe stage.
Got it.
When nothing can be done. That is when they come on their own.
Right.
I have problem in seeing, and when the doctor examines, the disease would have advanced to a very severe stage. So it damages the retina, the actual portions of the retina where the vision is processed.
Right.
Whatever you see is connected to the brain, and all those things are there. So that's a complicated problem. Right. And it's a complication of diabetes.
Got it.
And it is estimated that about 12 to 18% of all diabetic patients are at risk for this problem. But we won't know who is that 18% unless we screen all the 100%.
Right.
That's a great challenge.
Right.
Unlike when you do a eye cam, you can use a torchlight to find out cataract.
Yes.
This is not like that.
Yes.
A specialist doctor, a retina specialist, should look into the eye using specialized equipment.
Yeah.
That is the ideal way to identify and diagnose this problem. Or the alternative is you can take a picture of the retina using a retina camera, fundus cameras.
Okay.
And someone can look at the image.
Okay.
So Aravind has kind of pioneered this way back in 2001, where we collaborated with diabetologists, because that is where all the diabetic patients come. So we cannot ask all diabetic patients to go to an eye hospital.
Right.
Nobody goes.
Yeah.
Because they don't believe even now that diabetes can affect eye.
Yeah.
Because they don't feel any problem.
Correct.
So people know about the heart connection, kidney connection, foot ulcer. That is all visible problems. So people understand that if you have diabetes, you have cardiac risk and all that. But even the providers, many of them don't know.
Yeah.
So that's a challenge with it. So we collaborated with diabetologists and trained a technician in the diabetes center and placed a camera there. Okay. Anybody can be trained to take a picture of the eye, inside of the eye. They have to dilate the eye and then take a picture. And that can be, we developed an in-house software platform using which they can send the image here to a retina specialist. He can just see the image and grade it.
Okay.
And that was designed to make it very user-friendly. The doctor just need to check a set of boxes.
Right.
Which will tell you what is the status.
Right.
And based on that, a report will go back to the retina, the diabetologist clinic. So they can print it out with the image and then explain to the patient.
Got it.
So this is your condition. So you better go immediately to the eye hospital. So we found that this is much effective than telling that as you're diabetic, you might as well have an eye problem. Why don't you go and have an eye checkup?
Exactly.
So this is more targeted.
Yeah.
More evidence-based.
Yeah.
So that has been happening, and we also have done some research studies and published telling that this is more effective than telling all diabetic patients to have an examination. Because it's a blinding problem, it's an evolving problem.
Correct.
So that hasn't happening. So when Google collaborated, we moved to a next level where now we have a artificial intelligence platform which can read and grade the images. You don't need a human.
Oh my God! So how accurate is it?
Yeah, so that is having very high sensitivity and specificity that got published recently.
Yes.
So if you just need to upload the image into the software.
Yeah.
So like Dr. Kim was explaining, so if you stand on a weighing machine, you'll see
the weight. Yeah.
It's like 10-20 seconds.
Yeah.
You will get grading.
Okay.
Yeah. So that is enough for first level screening.
Okay.
So that otherwise we have to ask people to travel to a place Or even if in the other model, you have to wait for the retina specialist to grade and send.
Exactly.
In our kind of a situation where they see like 500, 600 patients a day in the retina clinic, it will not be very easy for a doctor to come out and see the images and respond promptly.
Right.
So that is where it adds value. And Google has been working with us in developing it.
Okay.
So because we had to train the software.
Yeah. Training is the most important thing.
Giving all possible pathologies. That is how you write the codes.
Right.
Write the program. And then they are going much beyond eye care. I think they have found out that with other specialists that looking at the retina image, you can even predict other problems.
Oh.
Like even cardiac problems and things like, because it all has this vascular connection.
Okay.
Blood supply and all that. Then even within eye, now there are being field trials going on to test the efficacy of this model to diagnose other problems like glaucoma.
Okay.
Which are all image based.
Yeah.
So that is where Google comes in, and then this has been proved scientifically that it's effective. Right. Not to replace a specialist, but for first level screening.
Right.
So this can happen anywhere.
Yeah.
Physically, you don't have to be near a doctor.
Yeah.
So that is the advantage.
So is this like a global solution Google has, or is it only for in India? I mean, retina.
They have not made it like open thing now.
Okay.
Because still field trials are going on.
Okay.
Yeah. So we the sensitivity and specificity has been established.
Okay.
That is published, and now we are doing like a actual field trial where we do it internally also. In the Journal of Ophthalmology, we are using this. And otherwise, what happens is sometimes unnecessarily a lot of people are referred to the specialty clinic.
Exactly.
Just to confirm or rule out.
Yeah.
But this will help filtering out so make it more efficient. And similarly for in our vision centers and diabetologist clinics.
Yeah.
So they can get an immediate response, feedback on the images, and then they can decide to either to refer or not to. So that makes it more efficient.
Awesome.
That is Google involvement.
So correct me if I'm wrong. So I mean, when I started reading about Aravind, I just thought it's a socio problem solved in a community-driven way. But then it has scaled. It has been helping organizations elsewhere also, and now it is incorporating tech to solve bigger problems. Yeah. And all with respect to eye. I mean, the niche is always going to be the eye.
Yeah.
And everything related to the eye.
Yes. You're correct. Yeah. So technology, the inclination towards technology has always been there.
Right.
Like we might be one of the very early organizations, at least in eye care, to have our own hospital management software.
Right.
We have our own IT division. That is all because of our founder's vision, and then always he was very much for leveraging technology wherever it adds value.
Right.
To make life easier, not to show that we have this gadget in our place. So that has always been there, and even we use technology in ensuring quality, in doing analysis of the operational data and monitoring the different parameters. So always that drive is there. What can we do? What better we can do? So especially because we have an IT team, they also come up with they develop a lot of things, and now we are into electronic medical records. Because that has been there in the market, but many of them are like commercial products, but many of them will not fit into our own flow, because we have all the years evolved like a system, which is kind of very efficient.
Right.
But the softwares are available in the market need not be planned for this kind of a system.
Right.
They might plan for the average market.
Right.
So that is why we couldn't use something that is existing. So we took time to develop it on our own.
Okay.
And now we are collaborating with other big centers like Shankar Nethralaya, L.V. Prasada Institute, and they have formed like a consortium.
Okay.
Because there's a lot of learning, cross-learning that can come
Yes.
And we can also share it with others. So technology has always been very well appreciated and then deployed.
I think that's one of the reasons why it is so important for Jagriti Yatra also to come here every year. Yeah. And I think that's about it from my interview perspective. Thank you so much for giving me time. I said 10 minutes and it took 20 minutes of yours.
Oh, really? It was nice to reflect. No? You don't usually get time to reflect on it. When somebody asks, you get to think about it and then...
Thank you so much.